Thank you, ma'am, for the kind introduction. So I'll be moving forward into the aspects of diagnosis of PPHN in neonates. Some of the aspects have been covered already by Dr. Harkirat. So the overview of the presentation will include the clinical features, utility of the chest X-ray, use of echocardiography, and how do we assess the severity of PPHN, which is one of the causes of hypoxic respiratory failure in a newborn. And there will be several parameters in echo which I'll be talking about. So I will try to cover all the parameters. So that makes my talk a little bit of lengthy, but I will try to finish in time. And some take-home messages. So as we have already learned in the morning lectures, that the aspects of clinical features are not actually only limited to term and post-term baby. So this is the usual scenario which we get. And so basically, the setting will be all the acute etiologies which have been described. So more or less, the baby will be a term or a post-term baby. Also, preterm babies, as has been described in the early lectures, can have features of PPHN. So they will be, so the classical signs is that they will be having some amount of respiratory distress, like which includes tachypnea, chest wall retractions, which is due to the acidotic component, which has been explained clearly in the pathophysiology of PPHN along with central cyanosis. So the classical feature will be labile hypoxemia, because we know that the pulmonary vasculature is sensitive to any change in the oxygenation. So the pulmonary artery blood vessels, they respond whenever there is a hypoxemic event. So in that way, the vessel constricts and the baby will have labile saturations. In this, there is usually seen a preductal and a postductal difference of around 5 to 10%. And there may be features of shock, as has been explained by the earlier lectures, in which we have features of left ventricular dysfunction. So the features may or may not be present. So these are the supportive features. Whenever we have a baby with PPHN, if there is a pre and a postductal oxygen saturation difference of more than 5 to 10%, then it is indicative that the baby might be developing PPHN. And if we do an arterial blood gas, that will be suggestive of hypoxemia, plus the PCO2 on an arterial blood gas may be normal or high. So if it is an idiopathic condition, the PCO2 will be normal. But if the PPHN is secondarily ascribed to any other cause, due to a lung parenchymal condition, the PCO2 may be high. So one more thing which is there in PPHN is hypoxia in neonates, which is disproportionate to the X-ray. Classical example is that of a primary, also known as idiopathic PPHN, in which the lung fields will be normal. The chest X-ray will look normal, but there will be element of hypoxia. Also, as we have going in the research stage, so various biomarkers have been studied. So one of the biomarkers is BNP, that is brain natriuretic peptide, and also NT-proBNP. So what has been suggested at the level of 550 picogram per ml, if it is greater, it has a sensitivity of almost 85%, but specificity of 100%. But I have written, there is no conclusive rule based on various studies, because this BNP can be falsely elevated in conditions in which there is left heart overload. So that is why the sensitivity has dropped, and there is no conclusive evidence as of now regarding the BNP. So then the modality of chest X-ray. So basically, evaluation of the lung parenchyma can give the clues to that what is the etiology of PPHN. I'll be gradually showing you some of the X-rays, which is the secondary cause of PPHN. So as I have told that idiopathic PPHN, usually the picture is of a black lungs, suggestive of decreased pulmonary blood flow. But there is absent parenchymal lung disease. So as we have seen that this idiopathic PPHN is a challenge and very difficult to treat, as compared to the types of PPHN who are secondarily associated with other disorders. So what could be the findings depending upon the cause? So if there is a preterm baby, then you may have radiographic findings of respiratory distress syndrome or a pneumonia or a meconium aspiration syndrome, where early institution of surfactant might help. Okay, so this is the X-ray. So as you can see in the leftmost upper X-ray, so here as you can see that the complete parenchyma is black. So there is no lung pathology. So this is called as idiopathic PPHN. The second X-ray on the right upper topmost screen. So as you can see that there is a heterogeneous lung disease where there is bilateral patchy infiltrates, fluffy infiltrates. So this is classical X-ray of a baby having meconium aspiration. Then as you can see in the third X-ray, you can see the parenchyma is involved. The bilateral, there are patches involvement, which is distinct from the meconium aspiration. So this is a classic X-ray of a baby having pneumonia. Then, as we have previously seen also, this is the last X-ray shows about the left-sided congenital diaphragmatic hernia. You can see the loops of the intestines are on the left side, and that has displaced the mediastinum, and that is why this is the heart. The heart border is pushed to the right. So echocardiographies. Echocardiography, as far as neonates are concerned, is the gold standard for diagnosis of PPHN, as compared to adults, where the gold standard is cardiac catheterization, because it is technically challenged to put a catheter in a newborn. So echocardiography remains the gold standard. So it is must to rule out the congenital heart disease, which may present with a fixed amount of hypoxemia. So if you see a baby in which the saturation is very variable, it is changing a lot, that means it is going in favor of a PPHN. Whereas in case of a critical congenital heart disease, the oxygen saturation will be fixed. So this is one of the parameters to distinguish it. And these are the classical features, 4 classical features of a baby with PPHN. So due to high pulmonary vascular resistance, there will be right ventricular hypertrophy and also dilatation of the right ventricles and along with the right atria, because the pressures are going up instead of coming down. Then because of the increased pressure of the right ventricle, it will shift the interventricular septum to the left. The third finding is across the ductus arteriosus, because the transition at birth has not happened normally, and usually what happens is, as we have learned from the previous classes also, that once the baby is born, due to oxygenation and the pulmonary vasculature, pressure drops and the shunting is from left to right. So in case of PPHN, that changes, that there is a reversal of shunt from right to left, and this right to left shunting is responsible for baby having hypoxemia. The fourth classical finding is the tricuspid regurgitation jet. And then we have several pulmonary pressure measurements, which I'll be talking about. And the fifth thing is we have to also, while doing PPHN, we have to exclude critical congenital heart disease, because that is important. The management changes in 2 different directions. And we have to also make sure that whether we are seeing all the pulmonary veins draining into the left atrium or not, because classical condition in which there is a confusion between PPHN is TAPVC. So this is the diagrammatic representation. As you can see that if the systemic vascular resistance is more, the blood will flow from the aorta via the ductus to the pulmonary artery. Whereas in the right diagram, as you can see, if the pulmonary artery pressure is more here, it will lead to reversal. The left to right shunt will become the right to left shunt. And also because of the increased pressure in the ventricles and the atrium, the foramen ovale, the direction of the blood will be from the RA to the LA. So this is a basically a very easy diagrammatic representation, imagining the heart as an ice cream cone in which the apex, which is usually found by the left ventricle, and the base. So this is the apex and this is the base. The base is primarily formed by the left atrium and then the vessels above it. So echo. So here, as you can see, you can clearly appreciate that this is a 4-chamber apical view. I'll be talking about the probe position and the views also. So this is a classical example of a PPHN where you can see the left atrium and the left ventricles, they are small as compared to RA and RV. This is due to the increased pulmonary pressures. And this figure shows, this is the 2D image in the echo. This shows you the Doppler and the TR jet. So this thing is the TR jet. So this is an overview of the clinical presentation of the child having PPHN, labile oxygenation, pre and the postductal difference, hypoxemia, which is disproportionately to the degree of parenchymal lung disease. You can see this is the TR jet. This is the TR jet. So echo is the gold standard, and quite a few years back, this hyperoxia, hyperventilation test was there, but now it has been abandoned because of the problems with hyperoxygenation and also with the problems of hyperventilation. So hyperoxia leads to free radical injury that can particularly affect a preterm lung who is already vulnerable to increased amount of oxygen, and hyperventilation, particularly in a preterm baby, because that will cause hypocarbia. And hypocarbia is a risk factor for development of periventricular leukomalacia later on, and also in the future spastic diplegia. So this test is actually abandoned now. So how do you assess the severity of hypoxemic respiratory failure? We have various indices. First of the indices is oxygenation index. So the formula is FiO2 into the mean airway pressure into 100 divided by the PaO2. Usually most of the sick newborns, when they are admitted in the NICU, usually they have this umbilical artery catheterization. So here the point to remember is we have to take the pre-ductal PO2 and not the post-ductal PO2, because the post-ductal PO2 can be falsely low. Okay, so that can, if the PO2 is less, that means the denominator is less, overall the OI is high. So the severity is, so normal is less than 15. So mild hypoxic respiratory failure is when the OI is less than 15, moderate is 15 to 25, severe is 25 to 40, and very severe is 40. So somewhere around moderate, you need the institution of inhaled nitric oxide, and very severe, this qualifies for initiation of ECMO, an oxygenation index which is more than 40. The second severity score is the PaO2 by FiO2 ratio. So usually the normal value is less than 200. So mild is 200 to 300, and moderate is 100 to 200, and the severe is less than 100. Then there is an entity called which is known as A minus a DO2. So basically, this estimates the partial pressure of oxygen from the alveolus to the aorta. So the big A is the alveolar pressure and the small a is the arterial pressure. So normally it is 4 to 20. If it is more than 600, then it is also goes into the category of severe HRF. And this qualifies again for initiation of ECMO. So we have an online calculator, which is available on the perinatology.com site. So I think while assessing PPHN, we should also side by side score the severity, because that will in tune guide you the treatment, that what should be the treatment at that point of time. So the last is a non-invasive way. See, oxygenation index is by putting a central line catheter, but we have some other index such as OSI. OSI is, the formula remains the same. a little bit different from the OI. Instead of the PaO2, here we have pre-ductal SpO2. So this is one of the ways of assessing the severity of hypoxic respiratory failure. And usually the correlation is that the oxygenation index is twice as that of OSI. So now the echocardiography. So the various measures are, one is the peak TR-jet velocity. Then what is the pattern and flow velocity across the ductus arteriosus that we have to look out in the echocardiography. Then other indicators of PPHN in echo, such as the time to, this TPV is time to peaked velocity divided by the or pulmonary artery acceleration time. And then this TPV is time to peaked velocity divided by the right ventricular ejection time and also the position of the interventricular septum. So these are the ultrasound probes which are available. So usually in cardiac ultrasound, we usually go with the sector probe. This one is the sector probe. This is the linear probe. Actually, this we use in doing lung ultrasounds, and this can also be used. And also this is the curvilinear probe. As you can see, this is a curve. So curvilinear probe. So usually the marker, you can see these markers have to be on the left side whenever we are doing the cardiac ultrasound. So these are the various probe positions. You can see this is the suprasternal, this is the high parasternal. High parasternal is between the second and the first and the second rib. The low parasternal is between the third and the fourth, and this is the apical. So these are the probe positions. And these are the various echo views. This is the left parasternal, this is the apical, this is the subcostal view, this is the suprasternum, and that means in the suprasternal notch, and then there is the right parasternal. This is actually the high right parasternal view is actually the ductal view, where the probe is kept in the second or the third intercostal space, and the marker, as I showed you, is towards 11 o'clock or 12 o'clock. So these are the echo views. This is the parasternal long axis view, low parasternal long axis view. So here, this will be the direction of the probe. The pointer is towards the 11 o'clock. You can see this, if we assume this as a clock, this is 12 o'clock, this is 11. And short axis is just perpendicular to the parasternal long axis view, this one. So this is parasternal short axis view at around 1 o'clock. This is the subcostal view, this diagram, just below the xiphisternum. And this is the apical view, where we usually try to get the TR jet. So measurement of the peak TR jet velocity, what we do, as I told you, that we usually start from the apical four-chamber view, apply the color. I'll show you a subsequent video of this TR jet also. So apply the color TR jet. We use usually continuous wave Doppler. So suppose if the TR jet velocity is around 3, so we use this equation which is known as modified Bernoulli's equation, that is 4V square. So the right ventricular systolic pressure is actually 4V square plus the right atrial pressure. So usually we take the right atrial pressure to be about 5 millimeters of mercury. And if you put the TR jet velocity in this formula, you will get the pulmonary artery systolic pressure. So this is the classical TR jet. You can see the blue jet, the blue jet. So whenever you are seeing the blue is more than the red, then that means a regurgitation. Instead of the blood coming down, it is going up from the RV to the RA. And this is the Doppler. This is the measurement of the TR jet. Okay, so suppose the TR jet is 4. So from the Bernoulli's theorem, it will be 4 into V square. So that will be 64. So if you add 5 onto that, that means it is 69. So actually the pulmonary artery systolic pressure is 69. So that is quite high. So this video I'll try to play here. See, you can see the blue jet. This is the RV. This is the RA. And if I stop this, See, this thing is the R. This thing is the R. Okay, this thing is the RA. Okay. So blue jet. ऊपर वाला. Okay. So this is the position of the interventricular septum. Hmm. So usually if the septum is O-shaped, then that is normal. So that means the right ventricular pressure is less than 50% of the left ventricular pressure. If the septum is D-shaped, that means the pressure is around 50 to 100. And if it so, as the pressure increases, the shape of the left ventricle also changes from O shape to D shape to crescent shaped. So as you can see, this is the normal curvature in which there is normal RA pressure. Here, due to moderate pH, the septum is flat. You can see the septum is flat here. And because of the high amount of pressure, the septum has bored. This is the left ventricle. This is the right ventricle. The septum has bored into the left ventricle. So this is the shunt. This is about the shunt evaluation at the level of the PFO. So this is usually the left to right, the right to left shunt in cases where the pulmonary pressures will be high, because usually the direction is from left to right. But in cases of increased pressure, the shunt evaluation at PFO would be right to left. So how do we see the direction of the shunt? So usually, as I told you, the high parasternal view is the ductal view, and the pulse wave Doppler placement is here at the mean pulmonary artery here. And then we see that what is the pattern of shunt and what is the direction of shunt. So this is usually the three-legged stool view of the ductus. So this is the pure left to right shunt, where this red thing shows the aorta, the pressure in the aorta, and this one is the pressure in the pulmonary artery. So when the aortic pressure will be more than the pulmonary artery, the shunting will be from left to right. As you can see, this topmost, this thing is the left to right component, and this down one, so it is pure. So not much contribution from the negative. So above this baseline is positive, below this baseline is negative. So whatever, so if the graph shows this diagram, this will be mostly left to right shunt, as you can see here also. So this is bidirectional shunt. So that means both these components are coming. This is the left to right component. This is the right to left component. This is positive. This is negative. So actually, these things will be more clear. Recently, we had an echo workshop. So more clear when we do it practically. But just because I have to cover in the diagnosis of PPHN, I'm explaining all these things. So this is pure left to right to left shunt. So this thing is the pulmonary artery. So that means why this is above, because the pressure is more. So this is the pulmonary artery and this is the aorta. So as you can see in the previous diagram, mostly the picture was here above the baseline. Here, because of the reversal, there is right to left shunt. So normally, what is the definition? So usually less than 35 pressures is normal. Mild we classify as 35 to 45. 45 to 60 is moderate, and more than 60 is severe PPHN. So this is one other parameter to assess in echo, which is known as the pulmonary artery acceleration time. So pulmonary artery acceleration time is from the onset of the pulmonary arterial flow to the peak flow velocity. This is known as the PAAT, pulmonary artery acceleration time. So actually it is inversely proportional to the PVR. If the PVR increases, if the PAT shortens, then that means the pulmonary vascular resistance is increasing. So normally the PAT is more than 100. So if the PAT is less than 40, this indicates that the pulmonary hypertension is severe. So usually we have the measurement of pulmonary artery acceleration time in the short axis view. So this is the short axis view. See here the blood flow starts and the peak goes till here. So this isosceles triangle here shows the pulmonary artery acceleration time. And this one shows the right ventricular ejection time. So what usually happens with the right ventricular ejection time is, if the pulmonary pressure is more, the right ventricular ejection time increases. So it is also inversely proportional. One of the other parameters is PAT by RVAT ratio. This is the least accurate. So normally it is around 0.34. And if it is 0.179, that means it is suggestive of increasing PAT by RVAT ratio. So this is the table representing the pressures and thereby the significance of that. So more than 0.3 is normal. If it is less than 0.2, it is significantly high pulmonary artery pressure. So as you can see, this is normal here. So in the B diagram, you can see the PAAT. So the RVET is shortening here as compared to this diagram in A. And then there is a mid-systolic, see this notch from PAAT to, this is known as the mid-systolic notch. So whenever the pulmonary artery pressure rise very high, this notching comes. Here you can see there is no notch. It is a uniform curve here also. But here, this is known as the mid-systolic notch. So in nutshell, if we have to see the RV hypertrophy, one is eyeball assessment. The view is apical four-chamber view. Estimation of the pulmonary artery pressure is by TR jet. Also, we can see in the Planck's view also, the interventricular septum and the LV shape, they are classically seen in the parasternal short axis view. In the shunt direction, as I told you, high parasternal ductal view. PAAT again in the short axis, and this ratio, which is the least accurate, is shown by the short axis view. So I'll be just briefly talking about the ventricular functions, because this is not a very easy thing to do, because once we have the establishment of the pulmonary pressures through the echo, we need to see the parameters as has been described in the early classes, that whether we have features of systemic hypotension, whether we have RV dysfunction or we have LV dysfunction. So basically I've divided the topic into right ventricle and the left ventricle. And then again in the right ventricle, systolic function and diastolic function, and also in the left ventricle, systolic and the diastolic. So here we have the systolic function, which is visual. Then there is a measurement known as TAPSE. There is a tricuspid annular plane systolic excursion. The right ventricular S by D ratio, fractional area change, right ventricular output, and the diastolic function is E by A. This is these things are particularly important when, as we have studied in the previous slides also, that the PPHN, which is classically related to LV or right ventricular dysfunction, these are the parameters. The third type, the first was acute. The second was flow mediated. So the last one here, we need to see about the dysfunction. So whether PPHN is associated with shock or not. So it is not only the pulmonary pressures which we have to manage, we have to see the functioning of the heart and the systemic blood pressures also, apart from the pulmonary pressures. So this is the visual. This is the right ventricle. This is the right ventricular systolic measurement. So here we have to see that whether the RV is visually contracting or not, whether the ventricular cavity is dilated, is there any abnormal septal motion, or there is dilated pulmonary artery. These things we have to see visually. Here. So the second parameter is TAPSE. It is basically done in the M mode. Then it gives you information about the longitudinal fiber shortening. So we have nomograms for TAPSE, which will vary with gestational age, birth weight, and postnatal age. And if the TAPSE is less than 4 mm, then it is indicative for, then it is indicated that there may be a need for ECMO, but it also increases the death in infants if the TAPSE is diminishing less than 4 mm. So this is how the TAPSE is calculated. So this is in the diastole. As you can see in the diastole, the ventricular chambers will be more. Ventricular chambers will be dilated because more blood is there. So it is stopped. In the systolic, the heart is contracted. So this is the systole. So the amount of the tricuspid valve which moves from this position to this position, this is actually the TAPSE. Then something about fractional area change. So here we can do it in apical 4-chamber or RV 3-chamber view. Normally it is around 25 to 45%, and there is normative data also on FAC, which varies with the gestation and the postnatal age. And the formula is the end diastolic area minus the end systolic area divided by the end diastolic area. So as you can see on the left diagram, this is in the diastole. So this area is more. And on the right, this is in the systole. So we have to take this. Then is something known as right ventricular systolic to diastolic duration ratio. So it is an index which gives you information about the right ventricular, basically right ventricular functioning, both the diastolic and the systolic phase. And if there is an increased systolic by diastolic ratio, that is secondary to PPHN due to increased overload. So this is the S by D ratio. This is the systolic and this is the diastolic. So if it is more than 1.3, it is associated with increased need for ECMO. This is the RVO, the right ventricular function, which is expressed in ml per kg per minute. And this is the formula in which we take the pulmonary artery radius, we take the velocity time integral, the heart rate of the baby divided by the weight. So this is about the right ventricular output. This is the right ventricle output. So here, this thing shows the VTI. This is actually the velocity time integral. So you can see this is the right ventricular output. This is branching into two, the left pulmonary artery and the right pulmonary artery and the left pulmonary artery, and this is the aorta. This is about the measurement of the pulmonary artery diameter, this A. So the formula is 3.14 into the the diameter into the VTI, which comes like in the last here. See, as you can see here, the VTI is 16.5. This measurement is VTI 16.5 into the heart rate, which is what if we assume a baby is having a heart rate of 130 at that time divided by the weight, this becomes out to be 148 ml per kg per minute. So this is around in the normal range. Usually it is around 150 to 300 ml per kg per minute. So diastolic function is given by E by A ratio, and also we have a component known as pulmonary vein Doppler. This is done in the apical 4-chamber view. So what is E here? E is early phase of passive flow into which the majority of the filling occurs, and then late is the late atrial phase, during which the remaining third of the venous return to the ventricle is delivered. So this is the diastolic function showing the E and the A ratio. So this is the E and this is A. So almost it is the normal value is almost around 1. That is, here you can see 0.93. So if the E by A ratio decreases, that is mild, but in moderate PPHN, this will go up. More than 1.5 is moderate and more than 2 is severe dysfunction. So LVO, as we talked about RVO, this is regarding the LVO. LVO is normally 150 to 300 ml per kg per minute. Here also the formula will remain the same as we have calculated for the RVO. So we have to take the velocity time integral, and in the RVO, as we were taking the pulmonary artery diameter in the left ventricle, because the aorta comes out of the left ventricle. So here the aortic diameter will be taken. So again, the view is apical 5-chamber view. 5-chamber view is nothing but apical 4-chamber view plus aorta. So if the aorta gets added, it becomes a 5-chamber view. So what we do, we usually place a pulse level Doppler at the level of the aortic valve, and then we take the tracing to calculate the VTI. So this is basically some physics here. So here, as you can see, this is the velocity time integral. If you see, this is as a cylinder. So this is the area. CSA is cross-sectional area. Area is pi r square. This is the stroke volume. So this is VTI into CSA. As you can see, this is the area. So assume it is a aorta here. So here at the level of the hinge, we have to take the LVOT, and this is the pulse wave Doppler here. This is the pulse. So this measurement will be the VTI. So volume will be area into this measurement, which is VTI. This is the VTI, as you can see here, aortic VTI. This is the four chamber view. Okay, so this is the LA, this is the LV, this is the RV, and this is the RA. So here, this is the five chamber view where we are putting the pulse Doppler. So the parasternal long axis view is basically the preferred approach for taking the aortic valve diameter. So as I talked about the right ventricular functions, here there is also left ventricular function. So left ventricular function, again, the dissimilarity between the right ventricular and the left ventricular systolic function, that instead of TAPSE, these parameters will come in picture now: ejection fractioning and fractional shortening. In neonates, the ejection fraction is not very reliable. It is the fractional shortening which holds upper hand as far as neonates is concerned. And then there is an index which is known as TIE index, or myocardial performance index. Again, in diastolic function, we have E by A ratio, and pulmonary vein Doppler gets added here. So again, in the visual, we have to see that how is the LV contracting.
Dr. Abhishek, you need to wrap up.
Okay, yes. So basically, this can be seen in three views: long axis, short axis, and the apical four chamber view. In the eyeballing, we can see that how the radius of the left ventricular volume is changing in systole and diastole. So this is the representation of visual. See this here, the systolic function. So again, there is FS and EF. So usually neonates, we prefer the fractional shortening. So normal is around 27 to 42. So these are the normal parameters, and we usually see in the parasternal short or the long axis view. So this is about the fractional shortening. That how do we calculate? We have to basically take the LV end diastolic diameter and the LV end systolic diameter, and then divide it by LV EDD. So that will give you the FS, and ejection fraction is tripling, basically the cube of fractional shortening. So this is about the value of here. Normally it is more than 55, but less than 30 is severely reduced. So E by A ratio already I have spoken about. And so this is about the E by the E ratio. Normally E should be more than A. If E is less than A, then that will mean ventricular dysfunction. And this is about the pulmonary vein Doppler. Usually it is taken in the apical four chamber view. Less than 0.6 meters per second is abnormal. And then again, the MPI. MPI is basically the assessment of both the function of the heart, that is the systolic and the diastolic function. So when there is MPI increases, if there is usually the dysfunction of heart is there. So this we do in apical four chamber view. So this is important. MPI is inversely related to cardiac performance. This is about the calculation of the TIE index, which is the MPI, which is ICT, that is isovolumetric contraction time plus isovolumetric relaxation time divided by this is the ET. ET is right ventricular ejection time. So to summarize, basically we have to see the TR jet. Then we have to see that assess the shunt, whether it is left to right or right to left, or it is bidirectional shunt. And then measurement of TAPSE, TA, that is tricuspid annular plane systolic excursion, and also the TIE index. So these are in nutshell about the parameters to be assessed in PPHN. And there are some techniques which should also be done, such as invasive techniques, where there are only certain indications when it should be done. catheterization, MRI, and CT scan, basically to see the lung parameters and assess the left ventricular functions and the flows here. So take home messages is, so basically the PPHN is a disorder characterized by high pulmonary vascular resistance. Clinical features are important, which is supported by pulse oximetry and chest X-ray. This is the hallmark: hypoxemic respiratory failure, and echo is diagnostic. So I would like to acknowledge newborns of the unit and the beautiful book by Dr. Pradeep Shurivanshi sir, Atlas of Functional Echocardiography, and also literature from Professor Satyan from UC Davis in US and Professor Stephen H. Advin from Colorado Hospitals, US. And also Dr. Patrick McNamara, who was instrumental in writing the guidelines about targeted neonatal echo. Thank you.